For my presentation today, I will be covering the basics of arterial blood gases, or ABGs for short, and working through some case studies. This is a summary of what I will be covering in this presentation, which you can read through on your own. First, how are ABGs interpreted? Well, I'll be showing you how via the 4-step method. Step 1 is determining the type of pH problem the patient is experiencing, whether if it is an acidosis or alkalosis. Step 2 is determining the type of acidosis or alkalosis, meaning which primary system is causing the effects. And an easy way of thinking of which variable relates to which system is PCO2 is to the respiratory system as bicarbonate is to the metabolic system, which means if pH and PCO2 are acidic while bicarbonate is normal or basic, it is a respiratory problem. If pH and bicarbonate are acidic while PCO2 is normal or basic, it is a metabolic problem. And if all three variables are acidic, both systems could be involved. Step 3 is determining if there is the presence or absence of a compensation by the other system using the bicarbonate or PCO2 depending on the primary system involved. And then step 4 is determining if the compensation is complete, partial, or uncompensated. And uncompensated means having an abnormal pH value with a normal PCO2 or bicarbonate. And then partially compensated means having all three abnormal values. And lastly, complete compensation means having a pH within its normal range, while the other two variables will be abnormal. Here I broke down normal ranges and how to classify acidosis and alkalosis based on pH, bicarbonate, and PCO2 values. Additionally, ABGs can classify oxygenation status using PaO2 and SpO2, which are the values that determine the amount of oxygen in the blood and amount of oxygen bound to hemoglobin, respectively. And another addition is that alkalosis means basic and acidosis means acidic. Going to the first case study, Mr. Frank is a 60-year-old with pneumonia. He is admitted with dyspnea, fever, and chills. And before I go into the 4-step method, I have included my interpretation and have labeled the ABGs as acidic, basic, or normal, which is indicated by the letter inside the parentheses. So step 1 is looking at the pH. Because the pH is below the normal 7.4 value, it seems that they are experiencing acidosis and are acidic. Step 2 is seeing which system is at fault. And because the PCO2 is also acidic, it seems that this is a respiratory issue. Step 3 is seeing if there's a compensation present. Because the bicarbonate is above the normal 24 value, it seems that they're experiencing some alkalosis to compensate. And step 4 is seeing what kind of compensation, if it's partial, complete, or uncompensated. And because all three values are abnormal, it seems Mr. Frank is experiencing a partially compensated respiratory acidosis. Further assessing the ventilation status, because the PCO2 of Mr. Frank is outside of the normal 35 to 45 range, it seems that they're experiencing hypoventilation. Also assessing the oxygenation status, because it is at 89% of the SaO2, it seems that they are moderately hypoxemic. And to tie everything together, the cause of Frank's uncompensated respiratory acidosis, moderate hypoxemia, and hypoventilation status, it is a result of his pneumonia, which results in a decreased distensible lung tissue, decreased vital capacities and total lung capacities, and then increased inflammation across the respiratory membranes and increased fibrotic exudate buildup in the alveoli and the small bronchioles. Going into the second case study, Ms. Strauss is a 24-year-old college student. She has a history of Crohn's disease and is complaining of a 4-day history of bloody, watery diarrhea. Following is her ABGs. Again, going into step 1 is looking at the pH. And because the pH is also below the normal 7.4 value, she is acidic. And then step 2 is seeing which system is responsible for the acidosis. So looking at PCO2 and bicarbonate, it seems that both values are acidic, which means this is a respiratory and a metabolic issue. So then step 3 is seeing if there is a compensation present, which there is because there is no normal value of PCO2 or bicarbonate. So now to determine if the compensation is complete, partially compensation, or uncompensated, we have to go back and look at the pH. And because it does not fall within the normal 7.35 to 7.45 range, it is abnormal. And then looking at the other values, which are also abnormal, it seems that this is a partially compensated respiratory and metabolic acidosis that Ms. Strauss is experiencing. Furthermore, looking at the ventilation status, it seems that although the PCO2 is within the normal range, it seems that the rate and depth of breathing are slightly depressed, therefore slightly increasing the PCO2 in the system. Also looking at the oxygenation status of the PO2 and the SaO2, it seems that they fall within normal range, so she has sufficient oxygenation, a normal oxygenation. To tie everything together, the factor that contributing to her metabolic acidosis is the 4-day diarrhea she is experiencing, which directly results in a reduction of bicarbonate levels. Additionally, the slightly elevated PCO2 could be a result of respiratory muscle weakness due to a loss in electrolytes, or a side effect of any medications the patient is using to treat her disease, resulting in an impaired breathing or sedation, respectively, contributing to respiratory acidosis. Going into the third case study, Miss Yule is a 17-year-old with intractable unrelieved vomiting. She has some electrolyte abnormalities in her ABGs are as follows. So going to step 1 is looking at the pH, and because it falls above the normal 7.4 value, it seems that she is basic. And then looking at PCO2 and bicarbonate, it seems that both of them are basic as well, which means she's having a respiratory and metabolic issue. Step 3 is seeing if there's a compensation present, which there is, and step 4 is seeing what kind of compensation. Because all 3 are abnormal values, and the pH falls outside of the normal range, it seems that Ms. Steele is experiencing partially compensated respiratory and metabolic alkalosis. Further assessing ventilation status, although PCO2 is within the normal range, the rate and depth of breathing is slightly elevated, which is decreasing the PCO2 in the system slightly as well. Assessing oxygenation, because the PO2 and SaO2, both values fall within their normal range, it seems that she is normal and not hypoxemic right now. To tie everything together, vomiting is contributing to her metabolic alkalosis as it results in a direct loss in stomach acids. Vomiting can also be contributing to electrolyte abnormalities and pain, causing hyperventilation as a result from stress, fear, and anxiety responses, also contributing to respiratory alkalosis. Going to the fourth case study, an 18-year-old quadriplegic patient with the following ABGs as part of his medical work. And going to step 1 is looking at the pH. And because it falls above the 7.4 value, it seems that he is basic. And step 2 is seeing which system is responsible. And because the PCO2 is also basic, it seems that the respiratory system is at fault. And step 3 is seeing if there's a compensation present. And because the bicarbonate is acidic, it seems that there is one present. And step 4 is seeing what kind of compensation. And because the bicarbonate and the PCO2 are both abnormal while the pH falls within its normal range, it seems that they're experiencing a compensated respiratory alkalosis. Further assessing the ventilation status, because the PCO2 is below its normal range, it seems that they're experiencing hyperventilation. And also assessing oxygenation, because they are both within the normal range, they are not experiencing hypoxemia right now. Tying everything together, because quadriplegia is a result of CNS lesions, it is evident that the lesions are greatly affecting the patient's respiratory drive, lung function, and muscle activation. For the last case, a 55-year-old patient with GERD takes about 12 tons of antacid tablets a day. So step 1 is looking at the pH, and because it falls above the normal 7.4 value, it seems he is basic. And then step 2 is seeing which system is at fault, and because the bicarbonate is also basic, it seems this is a metabolic issue. And step 3 is seeing if there's a compensation present, and because the PCO2 is acidic, there is one present. Step 4 is seeing what kind of compensation, because all 3 values are abnormal, it seems that this is a partially compensated metabolic alkalosis. Assessing ventilation status, because the PCO2 is above the normal range, it seems that they're experiencing hypoventilation. Also assessing the oxygenation status, because they fall within the normal range, they have normal values. And the culprit for the metabolic alkalosis is a result of the excessive antacid intake, which results in excessive administration of bicarbonate. In conclusion, understanding ABGs help guide patient interventions by using PO2 and PCO2 levels to connect the patient's symptoms to their underlying causes. This knowledge enables clinicians to identify factors that worsen symptoms and implement targeted interventions to address the source, thus improving symptom management and patient outcomes. Thank you. And these are my references. Thank you again.